Okay, good morning, and it's a very big honor to interview Professor Dr. Daniela Garib, somebody that I've been reading her work for a while, and it's very interesting. Plus, she follows the line of work of Sheldon Peck, who is somebody I respect a lot. Myself, I'm doing my PhD currently on impacted canine, so I like all these eruption disturbances, and Daniela has published a lot. So I prepared for her 5 questions I would like to ask her. First question is, what alterations in eruption are more frequent in pediatric patients when the alteration in eruption it's a part of a genetic problem and when it's more of a local problem? And then if it's a genetic problem, how can we deal with it with local measures? Because we mainly intervene in the local measures. So I would like you to answer, and then I will ask you several questions regarding some of your papers that I've been reading.
Thank you very much. First of all, my pleasure to be here. It's a great honor talking to you and discuss dental anomaly pattern. And this question is very interesting because we have to monitor our patients during the mixed dentition. And maybe the most frequent eruption disturbance is the maxillary canine ectopic eruption. That is your subject of thesis. And it's interesting because there are many risk indicators for ectopic canines, like small lateral incisor that we can see in the early mixed dentition. Also, the ectopic eruption of maxillary first molars are also very frequent in the population, 4% approximately, and the ectopic eruption of the maxillary first molar is also a risk indicator that the children can develop more frequently the ectopic eruption of canine in the late mixed dentition. Infraocclusion of deciduous molars is also an important risk indicator, and the animal hypoplasia. So this is very important because the difference in treating the ectopic canine in the mixed dentition and in the permanent dentition is very different. So is the early intervention is much simpler. It have less collateral effects, less probability of lateral incisor root resorption. So training our eyes to identify those patients with risk for canine ectopic eruption is very important. So sex is important, the facial pattern, the hypodivergent patient are more affected, and also these dental anomalies that are risk indicators and can be diagnosed earlier in the mixed dentition.
Another thing that you didn't mention is distal pattern of eruption of the lower second premolar. It's also an indicator. Bachetti reported. I think you reported as well, and Sheldon Peck reported that. And the peck-shaped laterals, either absent or peck-shaped, it's more of a risk factor for impacted palatal cuspids, not as much for buccal cuspids. Buccal cuspids is more of a of a deficiency in the maxilla, right? You
It's
know,
true.
I'm very interested in this because I did my orthodontic training back in the 90s with Slick Van Arsdal at Penn, and he was a big guy in impaction of canines. So I've been watching my cases for 25 years, and then I decided to do a little study with my cases for my thesis, and I started reading your work, and it's very amazing. You mentioned enamel hypoplasia of the upper incisors, and there's a nice paper by Bartolo relating it to impacted central incisors and to other ectopic teeth. So, and also Sheldon Peck, when he explains the problem of the genetic cause, talks about enamel hypoplasia, HIM, we call it here. I don't know how it's called in Brazil.
Yes.
Hypomixation incisive molar. And it's something that the pediatric dentist can watch, you know. So it's very important because it's a risk indicator. I would like to ask you next, Daniela, this question. Let me read it here. What is the role of the orthodontist in the prevention and early treatment? And when does the orthodontist intervene late? And this has to do with the work by Erickson and Kurol and all these, many from the Scandinavian, even Julian Amuba and Kjellberg, they've done a lot of interesting stuff with extraction of primary cuspid. So I would like to know your opinion on this topic.
I'm very enthusiastic regarding the Sweden orthodontics, the conservative approach that they taught us, because it's much more simpler. Extracting canines when we realize the permanent canine is in an ectopic position, and the probability of success is high, 70% approximately. So I would recommend deciduous canine extraction for all patients with signs of ectopic eruption of maxillary canine. And additionally, if patient need a maxillary expansion, if the patient show the constriction of the maxillary arch, we can also perform a wrapped maxillary expansion. And for patients with class 2 malocclusions, the extraoral appliance, if patient accepts, at least during the night, would be a good simultaneous procedure, because you increase the probability of success. But the canine alone, the extraction of the deciduous canine alone, is already a wonderful option. And it's very interesting because the Sweden orthodontists that work in public health are very training for the early diagnosis, and it would be a important professional failure, not diagnosing the ectopic eruption of canine in the late mixed dentition. So it's very, I think, among the procedures of interceptative orthodontics, the extraction of the deciduous canine is a procedure full of scientific evidence.
You know that when you were talking, I remember the work of Julian Amuba. She talks about if the temporary canine is in the sector 2 or 3 of Kurol, and it is between 20 and 30 degrees, extraction of the primary canine is very effective. And then you mentioned the work of O'Neill, who says that if you use a cervical traction, you increase, combined with the extraction of the primary canine, you increase the chances of eruption to 80%. And then you also talked about the work of Power Short and other people that have published on that. I think even Erickson and Kurol. It has to do with the position of the canine relative to the lateral. I know that from what I read, that if it goes beyond the distal portion of the lateral incisor, then your chances of success with the extraction reduces. And then there is another controversy that I've been reading. I would like to ask you your opinion. We know from the work of Bonetti that if you take out the primary canine and the primary first molar, that you have better chances of eruption of the permanent canine. But recently there was a work in the AJO, Carlos Flores Mir, our common friend, sent it to me, and they say it doesn't make a difference. It's just by extracting the primary canine alone is the same. So we were following Bonetti guidelines for a while, and now we're going back to primary canines. I wanna know what you're doing and
yes, the rationale of the extraction of the first deciduous molar in the maxilla is allowing the first premolar to erupt, giving space for the ectopic canine. But the ectopic eruption of maxillary canine does not relate with lack of space. So I believe the extraction of the canine alone is enough.
Is enough. Now I want to ask you another question. What is your opinion on early intervention with palatal expansion for palatally impacted cuspids and for buccally impacted cuspids? Because it's a little bit controversial. We know from the work of Bacchetti that if you expand early, the palatally impacted cuspids tend to come to position. But then on buccal cuspids, there are controversial work. Some like Jacobi and others mention expansion as a measure, but for the buccal impaction, but for the palatal impaction in permanent dentition, they say it's not as effective. What is your opinion in that?
Yes, I think we should use the presence of constriction as a guide to decide if you perform RME or not. So regardless of the position of the canine, because there is no evidence enough to understand the behavior of extraction and expansion and extraoral traction for buccal and palatal canines. So it's not clear yet. I think future studies should separate buccal and palatal canine and understand the effect of each therapy on the canines, because most of the studies had palatal and buccal together, and canine that were in the middle of the alveolar ridge also. So it's very difficult to make a decision. So I prefer to guide this decision based on the presence of maxillary constriction. The question is the maxillary arch accepts an expansion? Does the maxillary arch accept an expansion? I think this is the question we should ask.
If it accepts, correct. I want to ask you a little bit more on the genetic stuff. I know you published on that a lot, and I was reading your I was reading two things. I was reading your study on, actually your publication on Dental Press, and then your study with Sheldon Peck. And I want to ask, I want you to develop for us a little bit more the concept of genetics, and also for other syndromes like are more frequent, like cleft lip and palate. I know you've worked on cleft lip and palate as well. I've read your papers on cleft lip and palate, and it's a local factor, of course, for impaction of canines, because there is no bone for the canine to come in. So I want you to broaden our view on the genetic stuff and on the syndromes on impacted teeth.
It is very interesting. It's a very amazing subject because the dental anomaly pattern raised the hypothesis that one single genetic defect can negatively influence many teeth. So the association of dental anomalies is not is guided for one of the same background of a the same background, genetic background, causing all different expressions of dental anomalies, agenesis, late eruption, small teeth, and ectopic eruption. We believe that because we know that tooth agenesis is a genetic dental anomaly. Patients with cleft lip and palate have an increased prevalence of dental agenesis in all the family of dental anomalies are also frequently observed in patients with cleft lip, because cleft lip maybe share the same genetic etiological factor of this type of dental anomalies. So I believe most of ectopic eruption, small teeth, agenesis, and the late development is part of a genetic background. But we have also eruption disturbance that doesn't relate to genetic. And the one example would be the retention of the maxillary incisors, because the maxillary incisors are very stable teeth in the point of view of genetic. And local factors as supernumerary teeth or trauma respond for most of the eruption disturbance of maxillary incisors. But a part of the central maxillary incisors, most of the ectopic eruption and the eruption disturbance, I believe that are due the genetic etiological factor.
Yes, you know, I read the paper. Actually, we published a few papers on impacted centrals, and we published a few case reports. And I was reading on the work by Chasu, and she talks about obstructive and obstructive causes where they have the supernumerary, the mesiodense, the odontomas, and then traumatic, where she talks about the cicatrization and all the interference and the eruption of the central incisors. I want to ask you something that I've seen in our patients, and I want to ask you your opinion. You see that for impacted cuspids, the prevalence, it's 3-to-1 female to male, while for impacted centrals, the prevalence is 2-to-1 males to females. And my thought was that probably causes because the males get more trauma, they tend to get more blows to the face. So I don't know if you see that in your population, but in our practice, we see that most of the impacted centrals are in males, you know.
I agree with you entirely.
Mm-hmm. The other question I want to ask you, do you see family pattern? Because we have in our studies a few sisters. We see the family pattern for impacted canines. They're bilateral, they're impacted in the palate. They're sisters, and when you see one sister, the next sister has exactly the same problem. So you see the family tendency, and you see on them either small laterals or missing laterals. So you tend to see that as well in your patients, correct?
Absolutely, absolutely. I have a patient at the clinic that we diagnosed the ectopic eruption of canine. It was a 11-year-old boy. And when we explained to his mother said, oh, I had a canine in the palate, and my father asked the dentist to extract the canine because we don't have money to have brace. So the patient, the 11-year-old patient, was treated in a simple way with extraction of the canine that was successful. The permanent canine erupt. And then his younger sister, a 9-year-old girl, when started the late mixed dentition, we took a panoramic radiograph, and the same teeth, the maxillary right canine was also ectopic. So mother, older child and younger child, all with the ectopic eruption of the canine. So this is an evidence. I think it was the first evidence of the genetic background of the ectopic eruption of maxillary canines.
Let me ask you something. You mentioned ectopic first molars. What is your general protocol? Do you do like distalization with little springs attached to an expander, like a Handelman arm, or do you put separators? How do you deal with it?
I prefer the handle appliance with the band and the hook distal to the first premolar. A very conservative way to treat. And the first thing we have to attack in the malocclusion, for example, the patient has the ectopic eruption of the maxillary first molar and also a posterior crossbite. First, we have to attack the ectopic eruption, and I think Handelman appliance is very, very good because it's fixed and is very effective with the solution comes with 1 to 3 months with no need of retention time. So I think it's a very good option to treat.
Let me ask you then another question on lower transmigrated cuspids and impacted cuspids, and also on transposed cuspids, upper cuspids. I want to hear what's your opinion. How do you deal with it? What do you think causes it? And share your knowledge with us on that topic.
I think this is a difficult topic because I think it's not very explored in the literature. I don't know any procedure for preventing the transmigration, so we have to treat, and the prognosis for traction is not good because there is a high probability of the root of the mandibular incisors interfere as a mechanical barrier for the traction. So the most common prognosis for transmigration of the mandibular canine is extraction. So this is not a good news.
What about transposed upper cuspids with lateral and premolars? When do you have to make the decision just to leave it transposed, just to not make damage, and when it's a balance? When do you make the decision of trying to jump the transposed? You know, being a hero sometimes can cause damage to the roots of the teeth. What's your opinion on that?
Regarding the transposition between canine and first premolar in the maxilla, I prefer to leave tooth in the transposed position. And but on the other hand, when we have canine and lateral incisor that are related to trauma instead of genetic, I would see the combine CT and analyze if the traction of the canine to its normal position would meet any root, the root of the lateral incisor. If there is a chance to meeting a root during the eruption path, I would maintain the transposition. But if we have a biomechanical way to put traction in the canine, moving it distally, I would do that.
Let me ask you another question, something I talked with Carlos. I gave a lecture to the University of Alberta on impacted teeth, and it was a question that it came up. Do you do CBCT in all your impacted maxillary cuspids, or do you go first with the Panorex and maybe the buccal opposite rule of Clark and look at it on the occlusal film or on the lateral set? Or do you go directly on all your impacted cuspids to CBCT on a cost benefit and radiation issue for the patient? What is your opinion on that?
It's a very good question. We have to discuss more, but I would, if we are talking about children in the mixed dentition, I don't see the need of CBCT. I think if you perform an early diagnosis of the ectopic eruption of the maxillary canine, you need only a periapical, Clark periapical, to check if the canine is indeed palatal displaced, and no need of CBCT. On the other hand, when we have a patient in the permanent dentition, when you have to put traction in the canine and plan the direction of the force, and also we have to check if there is any root resorption in the neighboring incisors, I think we would be the CBCT would be beneficial because would show the position not only of the crown but also the root of the impacted canine, and also would reveal if there is an important root resorption of the lateral and central incisors.
You know, yeah, on this work by Kurol, I was thinking they did the first paper on 1988, and then they did a review paper on 2000, and they said that the advantage of the CBCT is that you get to see the resorptions, 38% of the laterals presented, 9% of the centrals, and they say on a 2D film you cannot see it. And then after their work, many people came, and you see root resorption ranging from 30 to even 70% in their samples. On this topic, I want to ask you a question. What is, in your opinion, the role of the dental follicle for resorption of the laterals? We know Chaucer reports that follicles larger than 2 millimeters represent a problem, and then we know Yan reports that proximity of less than 1 millimeter represents a problem. But some people just think it's a hydraulic pressure of the cuspids on the lateral root. What is your opinion? Does the dental follicle has a role on resorption?
I don't believe the follicle has a role because during the normal eruption of the canine, we have the follicle all the time in touch with the distal aspect of the root of the lateral incisor, and no resorption is observed at all. So I think the compression of the enamel of the tooth germ against the surface of the root would be a problem for resorption.
And now the last question, because I know you have an activity coming up. What is your opinion on Becker's theory of just a local problem of, he sees the problem much simpler than Peck, for example, and they've been point and counterpoint in the AJO forever. They've been exchanging letters. Do you believe it's a local thing, just a lack of guidance of the root of the lateral, or do you believe it's a more complex problem?
I think it's a more complex problem. I would agree with Dr. Beck, because we usually see a patient with the missing lateral incisor in the right side and the canine impacted on the left side. I think it's not the morphology of the root that invites the canine to erupt in the palate, but the same genetic background, the same genetic variation that interfere in the size of the lateral can also interfere in the eruption path of the canine as a different expression of the same gene. I think it's more reasonable, this explanation. But on the other hand, in cleft lip and palate that have increased the prevalence of impacted canine, 20% of our patients with unilateral complete cleft lip and palate has the need of traction of the canine. We know there is an environmental background for the impaction. And patients with a genesis of the lateral incisor has more probability of impaction because it's more difficult to the canine come this way. There is no guide. The canine go furthermore until the central incisor, and in a mesial position, it's very difficult to upright into the oral cavity. So I think in patients, non-cleft patients, it's a complex explanation. It's a genetic background, as advocates Dr. Peck. But on the other hand, in patients with cleft lip and palate, I think Dr. Baker is right.
Okay. Thank you very much, Daniela, for your time. It was very enlightening, and looking forward to seeing you. Maybe see you in the AO if we have an AO in April next year. And I know you're working on a chapter for a book, where we're also working on a chapter for that book. So we'll keep in touch, and thank you very much, and would love to talk to you in the future and keep learning from you. Thank you very much.
Thank you very much for the opportunity. It was a pleasure for me.
Muchas gracias. Un abrazo.
Un abrazo.
Muchas gracias, Daniela.
Bye.
Chao.
Saludos. Hasta luego.
Ok, gracias. Beso.